Welcome to Evidence Mastery. I am Dr. Masao Tusi, and I am going to help you understand what myasthenia gravis is and how it is managed. Please note that this video is for education only and will not replace your doctor's advice. All right, let's dive in. Today, we're going to talk about myasthenia gravis. It's a pretty complex condition, an autoimmune one, that really gets in the way of that crucial link between our nerves and our muscles. But the good news is, our understanding and the treatments we have now have really changed the game for people living with it. So, here's how we're going to break it down today. We'll start with the basics. What exactly is myasthenia gravis? Then, we'll get into the science of what's happening at a microscopic level. After that, we'll look at the symptoms, how it's diagnosed, and the general approaches to treatment. And finally, we'll wrap up with the outlook and the most important things to remember. Okay, let's start at the beginning. What is myasthenia gravis, and who does it typically affect? I want you to imagine something for a second. What if you tried to hold a book up to read, but after just a few moments, your arms just gave out? Or what if by the end of the day, your eyelids felt so heavy you literally couldn't keep them open? This really deep fatigue, a weakness that kicks in with use, is right at the heart of what it feels like to have myasthenia gravis. So to put a formal definition on it, myasthenia gravis, or MG as it's often called, is an autoimmune disorder. And what that means is your body's own immune system, the very thing that's supposed to protect you, gets confused. It starts attacking itself, and its target? A very specific place, the communication point between your nerves and muscles. We call this the neuromuscular junction. The result of this attack is really the classic sign of MG, a muscle weakness that comes and goes. It gets worse when you use the muscles, and importantly, it gets better when you rest them. Now, this isn't an incredibly common disease. We're talking about maybe 15 to 25 people out of every 100,000. But what's really interesting is when it tends to show up. The evidence points to this bimodal, or two-peaked pattern. For women, it often appears earlier in life, usually in their 20s and 30s. For men, it tends to show up much later, typically between the ages of 50 and 80. All right, now we're going to zoom way in. To really get what's going on with myasthenia gravis, we have to go down to the microscopic level and see the battle that's happening right at that junction between nerve and muscle. Okay, so how is this supposed to work? In a healthy system, it's actually a really elegant process. A nerve impulse zips down to the end of the nerve. This signals the release of a chemical messenger, and that messenger is called acetylcholine. Now, let's think of acetylcholine as a tiny little key. This key is released, it floats across a super small gap, and it fits perfectly into locks on the muscle cell. These locks are the acetylcholine receptors, and when the key turns the lock, boom, the muscle contracts. Simple as that. So you can see when everything's working right, you get strong, reliable muscle contractions. But in myasthenia gravis, something goes wrong with this beautiful system. It gets disrupted. The nerve is sending the signal, but the message just isn't getting received properly on the other side. And that's what leads to the weakness. So the big question is, why? What's causing this disruption? And here's where it gets really fascinating. In the most common type of MG, the immune system starts making these, rogue antibodies. And these antibodies specifically go after the acetylcholine receptors, our locks. They mess things up in three main ways. First, they can just sit on the lock and physically block the key, acetylcholine, from getting in. Second, they can call in reinforcements from another part of the immune system, something called the complement system, which then comes in and actually damages and destroys the locks. And third, they can basically tell the muscle cell, hey, get rid of these locks, causing the cell to pull them inside and break them down way faster than it can make new ones. This really drives home the point that MG isn't a one-size-fits-all condition. The vast majority of people, something like 80 to 85%, have those antibodies against the main acetylcholine receptor, what we call AChR-positive MG. And there's a smaller group, maybe 5 to 8%, who have antibodies against a different protein called MuSK. MuSK is kind of like a scaffold that helps hold all the receptors in place. And then you have a third group, we call them seronegative. That just means the standard test for AChR and MuSK antibodies come back negative. It doesn't mean there aren't antibodies. They might have rarer ones, for instance, against a protein called LRP4, or others we are still discovering. Okay, so we've seen the battle at the cellular level. Now let's zoom back out and see how this microscopic fight actually shows up as signs and symptoms in a person's life. For many people, the very first sign is in the eyes. This is what we call ocular weakness. It might be a drooping eyelid, the medical term is ptosis, or seeing double, which we call diplopia. From there, if the condition progresses, it can move to what are called the bulbar muscles. These are the muscles in your face and throat, so this can lead to things like slurred speech, real difficulty swallowing, or just getting incredibly tired while chewing a meal. The weakness can also spread to the arms and legs, usually affecting the bigger muscles closer to the center of your body, like your shoulders and hips. And in the most serious cases, it can weaken the very muscles we use to breathe, which can become a true medical emergency. So you've got these symptoms that can come and go and affect different parts of the body. How does a doctor actually pin down a diagnosis? Well, it's a bit like being a detective. You have to gather all the clues and put the pieces of the puzzle together. The investigation always starts with listening to the patient's story and doing a thorough physical exam. There are even some simple bedside tests that can give us clues, like the ice pack test. It sounds simple, but placing an ice pack on a drooping eyelid for a few minutes can sometimes make it better temporarily, which is a big hint. After that, we move to more definitive tests. Blood work can look for those specific antibodies we talked about, like anti-AChR or anti-MuSK. Then there are electrical tests, what we call electrophysiology, that directly measure how well the nerves and muscles are communicating. They can actually show that signature fatiguing weakness. And finally, getting an image of the chest, like a CT or MRI scan, is really important. We need to take a look at the thymus gland, because as we'll see, it's often a key player in this disease. All right, so once the diagnosis is certain, the conversation shifts to treatment. And the goal here is twofold. We want to help with the symptoms, of course, but we also really need to get that underlying autoimmune attack under control. The approach to treatment is really multi-layered, and the evidence supports using different tools for different jobs. For day-to-day symptom relief, there are medicines called acetylcholine esterase inhibitors. These basically help keep more of that key, acetylcholine, hanging around in the synapse, giving it a better chance to find a working lock. Then, to quiet down the overactive immune system, we often use things like corticosteroids or other immunosuppressant drugs. Now, if someone has a really severe flare-up, we need to act fast. We have powerful, rapid interventions like plasma exchange, which literally cleans the bad antibodies out of the blood, or IVIG, which provides healthy antibodies. Looking at the long-term picture, surgery can play a role. And more recently, we have these incredible, highly targeted therapies that can precisely block specific steps in the immune attack. It's a really exciting development. I want to take a moment to really focus on one of those treatments, thymectomy. This is the surgical removal of the thymus gland, which sits right behind your breastbone. Now, the thymus is like a training school for your immune cells, and in a lot of people with MG, something's gone wrong there. So if there's a tumor in the thymus, called a thymoma, removing it is absolutely essential. But what's really key is that we now have strong evidence from a major clinical trial. It showed that even in people without a tumor, removing the thymus can lead to significant long-term improvement. It can reduce symptoms and lessen the need for other immune-suppressing drugs. So with all these treatment options, what does the future look like for someone with MG? Let's wrap up by talking about the outlook and hitting the most important take-home points. Now, one thing that's absolutely crucial to understand is a complication called a myasthenic crisis. Even though MG is very treatable, a crisis is a life-threatening emergency. This is when the weakness becomes so severe that it affects the muscles you use to breathe. It can lead to respiratory failure, and it requires immediate, urgent medical attention in a hospital, usually in the intensive care unit. It's the most serious thing we worry about in MG. All right, let's boil it all down to the key points to remember. Number 1, MG is your immune system mistakenly attacking the communication link between nerves and muscles. Number 2, the hallmark symptom is fatigable weakness. It gets worse with activity, better with rest. Number 3, getting a diagnosis isn't just one test, it's a combination of the clinical picture, antibody tests, and electrical studies. And finally, number 4, treatment is not one size fits all. It's a comprehensive strategy to manage symptoms and, most importantly, control the immune system. You know, we're really in a remarkable era for treating myasthenia gravis. For a long time, our main tools were like using a sledgehammer to suppress the whole immune system. But now we have these new targeted therapies that are more like scalpels. They can go in and precisely block the specific parts of the immune attack, things like the complement system or a receptor called FcRn that keeps the bad antibodies circulating. This really brings us to a final and, I think, very hopeful question. As these tools get even more precise, what will the future of living with MG truly look like? I hope you enjoyed this video. Please feel free to share your experience in the comments or ask questions. I will do my best to answer them. Please note that I won't answer personal questions. And if you found this video helpful, don't forget to subscribe to my channel.